Welcome back. Now that we've discussed the heart and neck vessels, we're actually going to talk about the peripheral vascular system and the lymphatic system as it's a continuation of the cardiovascular system. Remembering structure and function, I do want you to take some time to review the arteries and the veins, realizing that arteries have a high pressure, right? And that's what causes you to be able to get a pulse. However, the venous system is a low pressure system. So there's no pulsation and there's no pressure. Therefore, we need what we call the a peripheral heart pump, but really they are valves in the venous system here throughout that once blood flows down the venous system, these valves help move the blood into the different, what I'll call compartments, until they eventually move up back to the heart. Okay, so again, your arteries are a high pressure system, your veins are a low pressure system. Arteries being high pressure, you feel a pulsation. Veins being low pressure, there's no pulsation, and you need the valves or the peripheral pumps to help bring blood back up to the central area or the heart. And veins drain deoxygenated blood, right? It's also draining waste products from tissue as it's returning back to the heart. And again, that's why they don't have a pump to generate blood flow. This again is because these valves and the contraction of skeletal muscles, that pressure is actually moving that blood flow. So just like our heart is a muscle and pumps, our skeletal muscle actually does a very similar thing. And this is why we call that the peripheral heart or the peripheral pressure system. And each valve has a semilunar pocket, and this is what we call a valve closing up to prevent the backflow of blood. So how do we initiate this skeletal muscle contraction? We have to walk. Essentially, when walking, this calf pressure, the calf muscles will contract and relax, moving the blood up. So if you notice that in the contraction phase, your gastrocnemius and soleus muscles are actually squeezing veins and directing the blood back up. And when you have a patient that's laying down in bed and they're bedridden and they don't get up and they don't walk around, there's no way for that calf muscle to pump blood. If you're sitting on a plane too long, there's no way for that calf muscle to pump blood. So you need to move around. In the hospital, we have sequential compression devices, or SCDs, which you'll see in clinical, which will help create this skeletal muscle pressure or this movement to milk the blood proximally back to the heart. So take a look and reorient yourself to the physiology of arteries and veins. Next, we're going to look at the lymphatics and lymph nodes. And we know that the lymphatic system has three functions. It conserves fluid and plasma proteins that leak out of the capillaries. It's a major part of our immune system, defends our body against disease, and it absorbs lipids that are found in the intestinal tract. And there's four areas where lymph nodes are found. Okay, this is important, and I will test you on this. You need to know that you can find lymph nodes in the cervical area, cervical meaning the neck area, axillary, epitrochlear area, and the inguinal areas. Oftentimes we forget about the spleen and the thymus, right? But these are also lymphatic organs. And the tonsils can be considered a lymphatic organ as well. The spleen is located in the upper left quadrant of the abdomen, and it destroys red blood cells that are old. It helps to produce antibodies. It stores red blood cells, and it filters microorganisms from our blood. So it's a very important organ for the lymphatic system. Our thymus, it's flat, it's pinkish gray, it's a gland, and it's located in the superior area, this mediastinum area, right behind the sternum, in front of the aorta, lies right in front. And this is where our T lymphocytes and our B lymphocytes originate. And you might remember that from your pathophysiology first weeks, right? And this is where it starts to mature. Now, the tonsils are located right in front of the respiratory tract and the GI tracts, right in the back of your pharynx area. And sometimes they get inflamed and they get enlarged if there is some type of infection or inflammation occurring. Developmental competence. We're going to start talking about infants and children first, and we just want to know that in a child, the lymphatic system works just like it does in an adult, right? It has the same function at least. And actually, lymphoid tissue develops at birth and then grows really rapidly until you're about 10 or 11 years old. Now, by 6 years old, this lymph tissue is about the adult size. And then after, it gets even larger than an adult size, but by puberty, it starts to atrophy back. And then, then you're adult age, and they're all the same. They are relatively large in children, some of this lymph tissue, especially lymph nodes, the superficial ones, the ones that are very easy to palpate and feel. Even when a kid is healthy, they're pretty easy to feel, right? With infection, there will be swelling, there will be hyperplasia as well. And usually when you have enlarged tonsils, this is a good sign that there's some type of respiratory infection occurring. In pregnant women, we know from our cardiovascular lecture that hormonal changes cause vasodilation, right? So your vessels are opening up and allowing blood pressure to drop. We also know because of the growing fetus, putting pressure and the uterus is getting bigger, it can sometimes obstruct the drainage of the iliac veins and then inferior vena cava. When this happens, low blood flow will occur, and this will overall increase venous pressure, and you'll have edema. And normally with our pregnant patients, we'll see edema of the lower extremities. We might even see extra pressure in the vulva area, increasing the size there. It causes hemorrhoids because this is also an area where increased venous pressure can occur, and varicosities or varicose veins, usually in the legs. In our aging adults, the peripheral blood vessels get more tight and rigid, and we call this arteriosclerosis, okay? Arteriosclerosis, not atherosclerosis, which is cholesterol, but arteriosclerosis, rigidity of blood vessels as we age. And because of this, this is what's actually causing that systolic blood pressure that we noted in the previous lecture. Intermittent claudication. I want you to highlight this and study it more thoroughly for the exam. When you have intermittent claudication, it will impair your patient's ability to walk longer distances and go upstairs. It really does decrease the patient's quality of life. And this intermittent claudication becomes very painful because of their vessels getting more rigid, not allowing blood flow correctly to flow through the blood. Aging also is going to cause progressive enlargement of your calf veins. You will notice loss of lymphatic tissue in your older patients as well, and fewer lymph nodes become more palpable and they start to decrease in size. I want you to take a moment and think about what are some questions that you might ask in terms of subjective history or health history questions you're asking your patients that pertain to the peripheral vascular system. I would focus on things that affect the arms and legs. Like, do you have any leg cramps or leg pain? Show me where, right? Is it sudden? Is it aching? Is it burning? Is it stabbing? You want them to describe the pain. So ask them open-ended first, and then you can give them some more close-ended possibilities. You want to ask if there's a history of peripheral vascular disease. If they do say that it hurts when they're walking sometimes, or they start to feel muscle fatigue, remember this is termed claudication, that you want to know, like, how many stairs does it take before you feel this? How long of a distance are you walking before this occurs? Has this amount changed recently? Is it getting worse? Does it get worse with cooler temperatures or warmer temperatures? What relieves the pain? Remember, we're just using the old Cart's mnemonic. Is it worse at night? I ask specifically at night because night leg pain is very common in our older patients. And sometimes this can actually indicate that there is peripheral arterial disease. Usually at night, you get severe night muscle cramping in the calves. I do want to know if there's any changes in their ability to exercise, or are they trying something new? Is there a new exercise routine they're trying or a new activity? I want to know, and I'm trying to figure out, is the pain from a musculoskeletal etiology or is it something vascular, right? Is it because of the peripheral vascular system? Does the pain occur when they're dangling their feet, when they're walking? Does it hurt when they're rubbing their legs? Do they see any visible skin changes? Any changes in color or texture of the skin? I might even ask for male, is it changing their sexual function? Because this also has to do with blood flow to the extremities. I will ask for any history of other heart problems, smoking, diabetes, obesity, pregnancy, hypertension, any trauma, all the similar questions to our cardiovascular exam. I did mention I was asking for skin changes, and I'm looking not only for cyanotic skin changes, but also darkening of the skin. I'm looking for any bulging of veins, or you might ask if they have varicose veins. Do they use any compression stockings like many nurses do, actually, right? Because we're trying to help decrease that edema that can occur during our 12-hour shifts and move the blood. And do you use support stockings or compression stockings? Do you have any open leg sores or any open ulcers that you need to show me? You're asking them if there's any swelling of the arms and legs, right? And because we're also talking about lymphatic system, is there any lymph node enlargement? Or do you notice any swollen glands? That might be a better way. And then if they say yes, you need to old cart that too. And then last but not least, you're getting a comprehensive history of their medications, over the counter and prescribed, and their adherence to those, and smoking history, getting a pack year history. A 65-year-old patient is experiencing pain in his left calf when he exercises, but it disappears after resting for a few minutes. The nurse recognizes that this description is most consistent with what of the left leg? If you said ischemia caused by a partial blockage of the artery supplying that left leg, you're correct, right? A partial, because it gets alleviated or relieved after resting for a few minutes. What is ischemia? This is when there is not enough blood, a deficient supply of oxygenated arterial blood to the tissue. And when you have a partial blockage, it's enough insufficiency to cause some pain, but it can be relieved, right? So when you are exercising or exerting yourself, your oxygen demands increase. And so you just don't have enough for that moment. So partial blockage of the artery. Now we're going to move on to the overall physical exam. And we're looking at arms and legs. So again, you're going to look at skin. You do, and you might note musculoskeletal findings during that exam, and you're noting any neural findings as well. It will overlap with this. So later in the semester, when we go over musculoskeletal and neuro, this will all make sense, and you'll be able to combine some of this assessment. You want to make sure that the room temperature is appropriate, because if they're too cold or too hot, you can cause vasodilation and constriction, which will change your normal findings. If you have access to a carotid artery Doppler or an ultrasound machine, you might even be able to pick up the carotid artery. And this happens usually if you're on a cardiac floor or a trauma floor, but you're not walking around with this Doppler. So you're going to inspect and palpate. You're inspecting skin, hair distribution. You're looking for any visible breaks in the skin, masses, lesions, scars, discoloration, any skin ulcers. Do the arms and legs look symmetric in size? Right? Usually about a centimeter difference is okay, but more than that, it would be considered abnormal. looking for jugular vein distension, and noting any viscosities or varicose veins. You're going to palpate each of the pulse areas. You're going to check for tenderness, temperature, edema, and cap refill. And as we learned from the cardiac lecture, that pulses we measure, there's a grading for this, and this is the amplitude of the pulse. If you don't feel a pulse, or it's just not palpable, it's a 0. If it's very weak and thready, that's a 1+. 2+ is normal, brisk, expected finding. A 3+, it might be a little bit increased. And 4 is bounding, very full volume pulsing, very high pressure. Most people would consider a 2 to 3 being very normal. For our testing purposes, 2+ is normal. You're going to check and grade bilaterally, except for the carotid and except for the popliteal. This is an anatomical reason, a technique reason, but never again, I'm repeating this, you don't test bilaterally the carotid because you don't want to compromise blood flow to the brain. But the other pulses, the brachial, the radial, the femoral, the posterior tibialis, and the dorsalis pedis, you will check bilaterally because you're comparing. The popliteal, it's hard to check bilaterally because you often need 2 hands to complete the technique appropriately. You're going to check arms and then check legs, right? And so you see the sequence. And if you're checking the lymphatic system, you're checking for the epitrochlear lymph node. So you need to go back into your anatomy and find where that is. But I'll also show you in just a second. In the legs, you're going through the same thing, your skin assessment, but then you're also going to check the pulses of the lower extremities and check the veins. You're also going to check the pretibial area for any edema or fluid accumulation. So the nurse is performing an assessment on an adult and the vital signs are normal and the cap refill is 5 seconds. What are you going to do next? Are you going to ask the patient about the history of frostbite? Suspect that the patient has venous insufficiency? Consider that this is a delayed cap refill and investigate further. Or is this normal and you don't need any assessment? Well, we know that a cap refill of 5 seconds is a delay. That's way too long. We want a brisk refill of less than 1 to 2 seconds. This is consistent with sometimes if you are in a very cold room, it can cause your cap refill to be delayed, or if there's a decrease in overall body temperature. Other things that could delay your cap refill are cigarette smoking, peripheral edema, and even some anemias can cause your cap refill to be delayed. So let's actually find out where these landmarks are. You see here the radial pulse, so on the rad side or the thumbs up side, radial pulse, and you can see this bilateral technique, and then the brachial pulses, right, in the brachial area. Sometimes if it's hard to feel, if you have the person extend their arm, like do a bicep curl first and stick your hand in there, and then relax again, you might find the brachial pulse a little bit easier. The ulnar pulse is on the pinky side of the wrist, and then the epitrochlear nodes you can feel here. So if you have them extend their arm up and try to feel in that area, if they had epitrochlear lymph nodes, they would be found here. You should not feel those lymph nodes unless maybe there's an infection of the arm or the forearm, because think about how your lymph moves, right? It's going to move from your fingers to your wrist to your elbow area and then back up to your axillary area. So if you find any epitrochlear nodes, you're suspicious that something below the epitrochlear node is being infected or inflamed. When you are performing an assessment of a patient, you notice that there's an enlarged right epitrochlear lymph node. What do you do next? Now that you feel it, what are you going to do? Well, remember what I said about the anatomy and how it flows? You need to examine the patient's lower arm and hand and check for any presence of infection, lesions, open sores, inflammation. Moving on to the lower extremity pulses, you're checking the femoral pulses. The popliteal pulses require you to have them bend their knee a little bit, and you're really using 2 hands, a bimanual technique to get in there. If you can't feel it, then you have to have them roll over to prone and kick their leg up a little bit, and you can use your thumbs to press in and feel the popliteal. They're actually pretty deep in there. Then you see the posterior tibialis, and the dorsalis pedis pulses. And then you check inguinal lymph nodes too. While you are checking femoral pulses, you can move around in that area. Now note that some of these things are not going to be required of you in lab, so check with the lab rubric to see which of these skills you're going to demonstrate on one another. Note that older adults, usually older than 45 years old, but I'm talking to oldies but goodies, sometimes the posterior tibialis pulse and the dorsalis pedis are a little bit harder to find. And sometimes you can't even find them in the same area on the two different feet, right? So you do want to move around a little bit, but do note that it is normal. And this is why if you had a Doppler, you could put it over these areas and note that there is pulsation because you can hear it now through the Doppler and not be alarmed. When assessing a patient, the nurse notes that the left femoral pulse is diminished. It's a 1+ out of a 4+ rating, right? So it's a 1+. What should you do? Should you just document it? Should you auscultate for a bruit? Should you check for calf pain or check cap refill of the toes? Well, the best answer here is you actually should auscultate for a bruit. Because the pulse is so diminished, you wonder, is there an obstruction there? What is causing this diminished pulse? So you auscultate for the bruit and you're trying to see if there's presence of turbulent blood flow. This could actually mean that there's partial occlusion. Next question. The nurse is reviewing the risk factors for venous disease. Which of these situations best describes a person at the highest risk for developing a venous disease? Remember that your veins need calf pumping, right? And so someone that is in bed for 4 days, not moving around, they are undergoing prolonged risk for venous disease. Also, anyone that has prolonged standing, sitting, are also at risk for prolonged disease. And this is why so many of us wear compression socks at work. So the answer here is B. Now, there are other reasons why you would be at risk. Not that these other patients are not at risk. It's just that the most risk is going to be found with immobility. The answer is B. Here you can see, as you're looking for varicosities, we typically look behind or posterior, normal veins, spider veins, and now we're moving on to very varicose veins, where those valves are not competent and the calves are not pushing up that blood back, and so they're pulling into these venous areas. You see here, you're looking for edema, and edema is any swelling and accumulation of fluid. And if it's just mild, we call that a 1+. You see here, 2 millimeters. It goes all the way up to 4+. And when it's 4+, this is what you're seeing here. It's very deep, it's pitting, and this indentation is going to last a longer time. Usually the whole leg looks very swollen and distorted. Important for you to know the different gradings for edema. How should the nurse document a mild slight pitting edema of the ankles of a pregnant patient? The answer here is A. The clue was mild and slight pitting edema. So that's a 1+. Okay, brawny edema. This is when you have non-pitting edema, but when you feel it, it's very hard, very tight, and filled with fluid. The Allen's test is an extra exam that we use when we're trying to test for collateral circulation of the radial artery or the ulnar artery. But you need to occlude both, right? You can see they're occluding it here, both thumbs on the radial and ulnar artery, and then you're going to open and close the fist, the patient is, and it should blanch. It should turn really pale. When you let go of the ulnar artery, you should have enough circulation now that everything pinks back up. If you don't, then that means that there is not enough collateral circulation. Well, why would we need collateral circulation in the first place? We might need to get an arterial blood sample, and we don't want to cannulate or insert a needle into that vein or a cannula into that vein getting blood, because it may cause compromise. There's no blood getting to the rest of the hand. Okay, so a normal return of blood should be less than 7 seconds. We're looking for the adequacy of collateral circulation. And you can see here, they compressed the artery, and on the ulnar and radial side, it blanched, and now they let go of the ulnar side, and it's pinking up under 7 seconds. This slide is showing the use of a Doppler ultrasound stethoscope. It's something that looks like a stethoscope on the top, but the bottom is the Doppler, and you're putting it over the areas of concern where you can't really find a peripheral pulse, areas of weak pulsation. And you're going to listen, and you're listening for any swishing sounds, which will tell you that there is pulsation. Some other abnormal findings here are listed on this slide, and some pictures to correlate. I'd like you to take some time to look at this and look at your book. And these are the abnormal findings I want you to check out and understand prior to the exam. I have another question for you. A patient has been diagnosed with venous stasis. Which of these findings would the nurse most likely observe? So venous stasis is when blood is not moving back accordingly, right? It's pulling into the veins. And when this happens, you might notice some brown discoloration of the skin. And this is because with chronic venous stasis, we get a byproduct of red blood cell degradation. This is called hemosiderin deposits. And these hemosiderin deposits stay in these areas, causing this brown discoloration of the legs. And this is a very telltale sign that there is some type of venous stasis. The other examples, pallor, cyanosis, atrophic shiny skin, unilateral coolness, these are associated with arterial issues, not venous issues. I have a couple more slides. We have for infants and children, transient acrocyanosis and mottling of the skin, which you see here. This happens when you're not getting a lot of blood flow through. Pretty normal, especially in the beginning where we're just having blood shunting to the rest of the body after delivery. And you should note, though, that even as an infant and a child, your pulse forces should be normal and they should be symmetric, right? They should be 2+, bilateral, and symmetric. And this is true for the upper and lower extremities. When there's any weak pulses, this is due to vasoconstriction, and it might mean that there is diminished or less than best cardiac output. For our pregnant women here, we've noted that varicosities and varicose veins are of troublesome diagnosis for them. And usually you will see bilateral pitting edema. Remember, this is a bilateral pitting edema is a 4+ in the lower extremities. And this usually happens towards the end and into the 3rd trimester, end of the day. But after they deliver the baby, this extra fluid gets diuresed, and they should not have edema any longer in the postpartum period. So give it about 10 days, and usually this all gets diuresed. For our oldies but goodies, we might see that the dorsalis pedis and the posterior tibialis pulses are very difficult. We talked about that. We might see some changes: thin, shiny skin, thick, rigid nails, loss of hair on their legs, so uneven hair distribution. These are all normal with aging. So if you see a test question that asks about what is normal for an aging adult, this is the slide to review. Thank you for listening, and I hope that you have a little bit more knowledge about the peripheral vascular system. The last thing is to talk about the charting, and we'll be done for this presentation. Here, the subjective of a patient with healthy arms and legs, or a healthy peripheral vascular system, has no leg pain, no skin changes, no swelling or lymph node enlargement. There's no past history of heart or vascular problems, no diabetes or obesity. This patient doesn't smoke and is not using any medications. On inspection, extremities are pink and tan color without redness, cyanosis, no skin lesions noted. They are symmetric, and there's no swelling or atrophy of the extremities. Temperature is warm and Equal bilateral, pulses are present, 2 plus and equal bilateral, and there's no lymphadenopathy. That means there's no lymph node swelling. Note that here it just says all pulses present are 2 plus. So because they're all normal, they didn't list out the different pulse areas. But if you had an abnormality, this is when you would list out the pulses.